Welcome, everyone. Today, the topic is aging and IBS, what nobody tells you. My name is Joe. I'm a dietitian at Diet vs. Disease. We're a team of dietitians, nutritionists, mindset coaches, gut-directed therapists, and we specialize in gut health and digestive disorders. We're the experts on everything that goes in and everything that comes out. Now, today, I have the pleasure of hosting this live with two wonderful and knowledgeable dietitians on the team. Would you guys like to introduce yourself? Maybe Tim, you can go first.
Thanks, Joe. I'm Tim Matthews. I'm a gut health dietitian based in Australia. I've been with the business for over 5 years now, in November. I look after the service delivery. I look after some of our clients, and I love what I do. My Instagram handle is I help people poo better. So I am hopefully an expert in what comes out as well as what goes in. Yeah, that's me.
I love it. My name's Kirsten Watts. I'm based in Albuquerque, New Mexico. Been a dietitian for quite some time. My handle is not nearly as interesting as Tim's. I'm new to this company, not new to nutrition, so I've kind of seen it all, done it all.
Nice. I wouldn't say you're that new now. Maybe it's been 6 months, has it?
Yeah, we're going on 6 months. Yeah.
So, yes, what I'd like to cover today, if we've got the time, we're going to do understanding the hidden impact of aging on digestive health. We're going to do why IBS isn't just about food. So, what other factors impact IBS other than food? And the surprising link between gut health and other health issues, or gut health and longevity and aging well. There's a lot of interesting research and links there, which would be fun to unpack. So I will get us started with talking about these. I've got some white hairs in my beard now, and I can still sort of pick them out, but on my neck there's too many for me to hide that now. And the reason I bring that up is like what's happening is the hair follicles, the cells that produce the color pigment in my hair, they stop working as we get older. So this is a part of aging, and that same kind of wear and tear happens in your digestive system. And so over time, like the cells, the nerves, the muscles in your gut, they don't work as efficiently as they used to. And this impacts digestion, makes your gut more sensitive, contributes to a lot of issues that we see actually in the group. So, Tim, I want to start with you because in preparing for this session, you wrote about IBS is actually less common in older adults than it is in, say, younger and middle-aged adults, which goes against what I just said, and probably the topic of this video. So do you want to elaborate what you found there?
Yeah, I mean, the research seems to point to the fact that IBS seems to be less prevalent amongst older adults, but that may be due to lower detection rates amongst older adults not presenting to their doctors for assistance. It could be due to younger people being more motivated. It could be so there are lots of different factors, right? We also have to remember that as people age, they tend to self-select away from certain foods that cause them digestive issues. And without sort of decent guidance, people will slowly restrict their diet over time and stop eating certain foods. We also have the body aging. So, people are getting used to the way that they live. They are just dealing with the digestive issues they've got. That if it's their normal from childhood, they may be sort of unaware that the way that they're living is not normal. And so they may seek less assistance for what they consider to be just their normal. So there's lots of reasons why people might not be detected by the medical system for their IBS. We also have to remember that IBS is a diagnosis of exclusion. Some people don't go and get their issues diagnosed. A lot of doctors also aren't really interested in biological causes, which they aren't really experts in. And so once someone comes along with unknown digestive issues, if they do get diagnosed with IBS, that used to be, a syndrome of we don't know what's wrong with you, so now go away. A lot of people won't follow up after that.
Yeah. So anyone who's watching who's had IBS for a long time, so let's say more than when did FODMAP diet first researched in 2005, but not really talked about till 2015 probably. So, but if you had IBS issues like well before 2005 or 2010, what what were you told to do by the doctor? If you can leave it in the comments, because I actually am very curious. I don't know the answer, but what were the doctors saying? What were the nurses saying that you should do for your gut issues? Maybe they didn't call it IBS. Maybe it was just like I have, very irregular bowel habits, and it's super problematic for me, and it's been a long time. Um, were you given any instructions on what to eat or not to eat? Were you told that's just part of growing older? Were you told to take an antidepressant? I mean, I've heard all sorts of things. So we'd love to hear your story there.
There are quite a few old terms for IBS. One is spastic colon.
Mhm.
It's a very common one that I see some of our older clients bringing.
Yeah.
I remember from my own family, my dad was told that he had a syndrome, and they didn't know what was wrong with him. Some of our clients get told that it's all in their head, which is a terrible thing to be told, and not to be given any certainty,
Mm.
to be sort of gaslit by the medical system.
Mm.
So yeah, definitely lots of terms exist.
Hmm. They call that medical hexing.
Medical hexing.
Yeah, not gaslighting. It's in the literature. It's well
Ah,
studied. When
Tell
you're
us
told
who's
something is
doing
not
medical
physical.
hex. Who's doing medical hexing?
It's when you go to a medical provider to get information about what's going on with you, and they sort of disregard you and give you this scary kind of label, and then you identify with it, and then your psyche identifies with it. So you don't remove yourself from the condition. It's not like I have a body that suffers from IBS. It's I am an IBS patient, right? So it creates this whole psychological sequelae, like this cascade in people, sometimes exacerbates their symptoms, especially
Mm.
when it's disregarded. But,
yeah.
IBS and IBD and celiac disease were all lumped under IBD around the turn of the 20th century, right? And so there's this famous doctor, I want to say his name's Valentine Haas, who treated and cured so many people with a basically low FODMAP, very specific carbohydrate, grain-free type of diet, but it was very low FODMAP. And the only starchy thing he allowed was green banana flour. So he was hugely celebrated until like, what was it, like the 20s or 30s when someone actually identified gluten. And then we started getting this differentiation of GI illnesses. So, like before that, it was like tropical sprue or celiac. Like everything was considered celiac. Sorry, not IBD. It was all called celiac. And then it started becoming Crohn's and ulcerative and IBS and diverticulitis or diverticulosis. And all of those are still thought to be initiated by dysbiosis. And whatever the input is that creates the dysbiosis for you, it's like, take whatever hand of poker you're given in life. You really never know what you'll present. But it's an interesting history. So I too meet people, especially in their 80s, who say, I don't know how long I've had this, but when I was 9, someone told me I had a spastic colon. And I'm like, okay, so you've had this since you were 9. And they're like, oh, I guess. But it does evolve, right? And so I think a lot of older people, especially if we're talking about elderly, they're trying to differentiate between what is serious and what's not because they know they only have this much time, 7 minutes, 15 minutes to get their most pressing medical need taken care of. And they put their GI they put their stress on the back burner and they're like, you know what, I'm having arrhythmias. Like, let's focus on my heart palpitation. So, globally, in the elderly population, prevalence is estimated at 10 to 20% of IBS, and with women having 4 times more than men in the elderly population. And it really starts at menopause. So, like 40 to 50 and above, women, like, they just outrank men with the condition. So, I think part of it is the medical system, right? And a lot of our research comes from wealthy Western countries. So, we're also not getting the picture of what happens in South America, what happens in Africa, what happens in Asia. So I think we should keep that in mind. It's pretty prevalent. Many
Mm.
people have these issues, even if it comes and goes, like post-infectious, then they go into remission, thank God, right? Like they never have it again. But with many people, it's chronic and it'll just kind of vacillate in severity.
Mm.
This is really fascinating. The story you mentioned about this first sort of pioneering doctor, and I think you mentioned, did you say that green banana powder
Green
was like
banana
was
flower.
A-okay?
Yeah, in fact, he like prescribed it to all. They would go get it from him. You can still see like in the SCD community, like there's still green banana flowers. It's very expensive now. I think part of it has to do with the crop. It's like coffee and cocoa, bananas, like equatorial crops are suffering.
Hmm.
So it's not cheap anymore, but it used to be even when I started practicing 17 years ago. It was super cheap.
I
Now it's
did.
not, and I have that guy's original work. Like I couldn't get it on microfinch, so I bought a book that's like Xerox copies of his studies. And he was like very celebrated, like globally, until someone identified gluten. And then everyone like ignored what he did, even though it still created so much remission for people. And they just went all about focusing. You know what the saying is, like we used to be holistic, then we became reductionist, and now we're trying to make our way back to a holistic approach in science.
Hmm.
He was caught like in that very reductionist,
Hmm.
like germ theory, penicillin, like everything kind of hit around the same time, right? So, but he's a fascinating guy.
Cool. Hey, this is the kind of nerdy stuff that I'm glad you're bringing to the table. You know, you're
Got
buying
lots of nerdy
you're
stuff.
buying these old books about gut health. I love it.
Well, you know, I
Let's
taught research. I taught evidence-based medicine for a decade, right? So
Mm.
always wanted to find like the original source, like where do
Yeah.
these ideas come from? Because we have had insane ideas in science. And so I'm like a pretty open-minded, nerdy person. When people are like, I think this is going on with me, I'm like, maybe you're right. Like maybe we're just missing something, which plays into gut health a ton, right?
Yeah, exactly. So yeah, I brought up the green banana thing because it's like still to this day that is like the fiber that is supposedly very beneficial. Um, you know, we're recommending it at certain points in time. So it's like it's so interesting. He was onto a lot of things
Yeah.
before we had reason for it, right?
Yeah. I
Um,
forget his remission rates, but they're large, like way past, like placebo is always around 40, 50%. Like it's the most amazing thing modern science has ever discovered. His remission rates were beyond that. So it was like true remission. And
mm,
bananas are interesting because what do bananas have? What is the one strain of probiotic bananas contain? And I can't remember what form, but it's a lactobacilli. So
mm,
not only do they come with prebiotic, especially in the green form, they're low sugar in green form. So not going to feed like candida type, you know, opportunistic ones. And they come with lactobacilli. So he was really giving this pre-probiotic thing and then taking away, for the most part, he removed a lot of FODMAPs from their diets. And I'm talking like kids, like he was curing pediatrics because he was a pediatrician. And then adults heard about it and started trying this too. So
mm. Too bad green bananas taste terrible, huh? But there's a product idea, whoever's inventive enough. So medical hexing. Can we go back to medical hexing for a moment? I read a study. Maybe did I post it in the dietitian's channel, or maybe you sent it to me on LinkedIn. But it was about like empathy from doctors and looking at female doctors versus
mm,
male doctors,
yeah.
and who is who is more likely to be doing medical hexing? Do you think that's a fair um, link to say that?
Yeah. So we taught about that. We researched that. So like the number one predictor of a patient's outcome is not the medicine they get or the surgery that's performed. It is their rapport with their physician or their primary provider. So whoever's providing them the care, if the rapport is not there, their outcomes are not as well. So when we do like regression and we look at like what is it about these providers with good rapport, we do see a big gender gap. Female brains are wired differently, and that kind of goes back to what you brought up earlier. Elderly women are 4 times more likely to get diagnosed with and have more severe IBS, 4 times more likely than their male counterparts. I think part of that is because I don't know about you guys, but when I have a guy, quite often he's like, I don't know what my body's doing. I'm taking care of A, B, C, and X, Y, and Z, and I don't pay attention to my body. And women are more tuned into themselves and their environment. It's just part of the way we are raised. And there's probably some ancestral like DNA popped in the brain too, because we do see these gender differences. So we do see less, but when you start looking at specialties, that can dissolve. So surgery is a good example. Female, male is still a problem.
Mm-hmm.
And part of that's related to the trauma they suffer in their training. But like as a general rule, I hate stereotypes, but you can assume that, but not every guy you go to is going to be dismissive, right? Like younger generations, like I literally taught my students about informed consent and appropriate consent and tuning in and all of that. We taught them emotional intelligence. So I think it's changing, but it's definitely specialty related, like above all. Like the more invasive, less human contact type of intervention, the more likely they are to, and it's not conscious. Most of them, it's not. They're just like in and out. Here's your problem. Here's my fix. Here's your problem. Here's my fix.
I
And
wonder
the
if
multifactorial, like, there's like what, like 15 different possible initiating events for IBS, right? So there's so many options.
I wonder if women have a higher base emotional intelligence than men, or why would there be that gender gap? But in any case, medical hexing, yeah, that's an interesting term. So it is gaslighting, but it's in the medical context. Unfortunately, so common. So we got some answers to my question earlier about what were
I'm
people
curious.
told before before we had all the solutions we have now. So Heidi said, "Hi Heidi, by the way, long time client. Take laxative every other day forever. Take fiber gummies. Take Bentley." Someone said, "Take Linzess. Eat more fiber and water." In the UK, IBS patients are a burden to doctors and their medical system. Well, the problem is the system. So, and I'm going to go a bit of a tangent, but I went to the American College of Gastroenterology conference in 2022 in Charlotte, North Carolina. And I was meeting with a doctor there. I had arranged like a meeting, like a quick 15-minute meeting in between the sessions. And he came out to me and we sat down and he was like, how can I help you? And I was like, hello, doctor. Like, thanks for meeting with me. I want to have doctors, refer us patients directly, because at the moment, what we see with everyone that we come across and work with is like, they went to the doctor, they didn't get a solution. They, walked around in the dark for a year or 2 years or 5 years, trying to figure out what to do, looking up things. And then they eventually find us and they all tell us the same story. And it's like, can we just bridge that gap and have the doctor just, come straight to us, or at least have that opportunity? And he said, Joe, do you know how much the gastroenterologist makes to do the colonoscopy? I was like, I don't know. He said $2,500. Do you know how much they get for an appointment after the colonoscopy is done? I was like, I have no idea. He said $25. And he said, and that's not the point. He said, the point is the list for colonoscopy is never ending, and we have to scope those patients because they're looking for, sinister things. So this is not a dig at doctors at all, but just the system that we're in, where it definitely doesn't make sense monetarily, but also for them to actually see the patients they need to see, for them to be doing follow-ups after your colonoscopy if it's all clear. And then you've got your PCP or your general practitioner who doesn't really have nutrition training and certainly probably doesn't specialize in gut health. And so then, as Karen has put here, to circle back, IBS then are a burden to doctors, and the system is more just like the system isn't set up. There's too many unwell people. They don't have the resources to help a particular kind of patient, and I imagine it's been like that for a long time. Fortunately, now we have the internet and online services as well, which can help with that. For example, our service. But just wanted to give you that little insight based on your comment there, Karen. It was a tangent. All right. Does anyone want to add anything else? Otherwise, we can move on to the next thing. I'm just having a look at the comments quickly.
Yeah, I guess the only thing I'll mention is, and to wrap up on the difference between women and men, is especially in previous generations, they were burdened with taking care of everyone. So quite often you'll meet a woman that is like postmenopausal, and she's known she's had this condition forever, but she's never had the time to start taking care of her health until she's older. So and I don't know the numbers on it, but I wonder if the utilization, like we know men go to doctors way less often than women. So I wonder if it's like a utilization thing. Like men would get picked up more if they actually went in, but it's women utilizing it twice as much or whatever. And that's why we see this discrepancy. But it's like they'll spend their whole lives taking care of kids and then husband, and then finally they, take care of themselves. So maybe that's part of it. I don't know.
Yeah, I definitely think because 4 times more, so certainly probably 4 times more likely to seek help than a proud, stubborn old man, perhaps. But let's move to the next topic I wanted to cover, which is why IBS isn't just about food. So what other factors are impacting IBS? So you kind of just touched on a couple things there. You've mentioned menopause. So let's talk about is there any known links with hormones in particular? Because then we could go to stress, because IBS is not just about food. And so it's like, okay, if we're getting older and IBS is more common, perhaps we're just more stressed as we grow older, or maybe more people are in a caretaker role, or have big responsibilities, or have financial stress, or maybe we're dealing with stress worse and worse. I mean, yeah, this can go many ways, but who wants to jump in there?
I think Kirsten's an expert in the comorbidities that exist in IBS and older adults.
Yeah. I was going to ask you though, Tim, if you had
this.
anything. That's a big packet to unpack, because so if we're talking about sex hormones, like sex steroid hormones, there's definitely a correlation with female hormones and GI changes. And this happens like in menses, right? So it's quite common for I did pediatrics, right? And I would hear the same story, like every month I get my period, I get diarrhea for like a day and then it goes away. And we're like, that's normal. Don't worry about it, right? Because there's this relationship with estrogen and insulin, GI motility, etc. So that's very tightly connected. And when you have really big shifts, like pregnancy, like you get a hysterectomy, like you go through menopause, it just like this big wave, like someone, dumping a huge rock in your calm little serene pool, and then you deal with the after effects of it, and then it'll settle down as the hormones are regulated. And there's this really interesting documentary that just came out on menopause care in the Western globe and how bad it's been. So it speaks to some of that. I would encourage people to watch it. It was on PBS. So there is like a relationship between sex, steroids, and GI motility, and this happens in men too. It's just they don't pay as much attention to their fluctuations because they don't bleed every month, so it's not as big a deal. They just chalk it up to something else. But then if we're talking about stress hormones, that totally leads us into mindset and the fact that we have this very integrated nervous system, right? We have these reptilian brains and then these primate brains, and then we have these like human only, very high functioning prefrontal cortex, but it's all integrated. And it originally was peripherally, like all along your spinal cord, all in your hands, your legs, your gut, one of the biggest sensory organs, right? So when you live with chronic low-grade stress, that leads to chronic low-grade nervous system dysregulation. And we know what happens in fight or flight, right? So whether you realize you're in fight or flight or not, if you're someone that tells me I run around all day, I don't have time for myself, I know what's happening with your nervous system. Like it's really unlikely you're in rest and digest, like a safe, healthy state. You're probably in fight or flight, and fight or flight turns off the GI tract. So there's all these like varieties of how hormones interact with motility. We know there's a change in, the microbiome. It's like if it senses danger, it shifts to deal with danger, right? So, yeah, I mean, I feel like there's a lot we could say about that. What about you, Tim? You have input?
So many things we could rattle off,
Yeah, I
but
know.
yeah, it's
Can I
interesting
jump in
that
with
yeah,
fight or flight?
hmm
So, because you're like, it switches off. So, just so people know, so like,
hmm
if you're in fight or flight, your body will restrict blood flow to the or take blood flow away from the digestive tract and go to your limbs because that is fight or flight because you needed to run or you needed to fight. And
hmm
so, if you're doing that on a chronic long-term scale all the time, then that's how it's impacting whether your gut is sort of switched on or switched off. So I just thought that was I heard that once and I thought, oh, that's a really interesting analogy.
mm,
Yeah, and it's just one thing. So when you're in, that's the parasympathetic autonomous nervous system. So that's fight or flight. So there's also like contracture, like freeze or faint. So everything is tense and not doing what it's supposed to. So your intelligence goes down, your creativity, your libido, your immunity goes down, and your GI blood flow goes down. So yeah, you don't make good decisions. So food seeking behaviors change, and you tend to seek foods that are more of a burden to the GI tract, right? So you're in a stressed out state. And then what we have accessible to us, like high fat, high sugar, the amount, like the quantity of nutrients we put into our systems now has never been seen except for the last 100 years. And I think people struggle with that because they'll see people running to Starbucks and doing everything they need to do to deal with the modern way we live. And they seem fine. And I'm always like, they're not fine. Eventually it catches up to you, right? But they're like, why can't my body do that? And the point is, no one's body can do that for long, right? So, like, it's stressed out, already not working. Then it's getting burdened with like a massive quantity, typically, of calories and sugar and fat. And it shuts down, so it can't do its job. And then so you got to find ways to shift into parasympathetic, where your libido comes back and your creativity and your digestion and your immunity. And that's, what all of our mindset coaches do with our clients. So, but there's a there's
it's
a
tough.
really big correlation, and people don't pick up on that low grade, that everyday stress, which adds up. Like they literally collapse at night, and then they wake up and drink coffee and go all day without kind of thinking like, oh, actually, this is really new to our systems. No wonder my body can't keep up with this.
It's definitely a tough one. A lot of our older adults feel stuck in their digestive issues in their situations because it's what they've known for so long, right? And I see, especially in talking to our mindset coaches, a lot of older adults who might be in their 70s and 80s who really aren't happy in the situation they're living in. They're truly not happy with their partner of 20, 30, 40, 50 plus years, but they feel truly stuck to do anything about it at this in the stage of life they're in. And creating that change is a big step for a lot of them. Someone choosing to leave a partner, someone choosing to move states, someone choosing to end the career that's still supporting them at the age of 60, 65 plus. They are sort of safe in those situations, even though those situations are not safe for them and their gut. And yeah, we need a mindset coach here really to talk to this. But I think some of the biggest change we see in people on our program is those who do step into the unknown. They do take that big leap, and they see that sort of global change in how they feel from being brave and making that change. So yeah, it's definitely a tough one, getting stuck in your own nervous system because it's what you know, rather than sort of trying to push out against it.
Mm-hmm. And
Yeah, some stress is good.
Well, some stress is normal.
Right, yeah. It serves a purpose. It's like infection, like inflammatory responses serve a purpose. So stress is there to alert you. You care about something and you want to do it. But when you don't ever get a break from that, your system can't function in that chronic state.
And people are just, do you feel like they're not aware, Tim, like your clients that come to us, they're not aware that they're in a state of chronic stress or hyperactivity, do you think, or are they aware and they don't need someone else to sort of highlight that to them?
I think people kid themselves, right? They kid themselves that they are not unhappy when they truly are unhappy. Or they kid themselves that they can continue in this situation when really their body is saying this situation is not good for us, right? Remember that whole gut feeling. I got a gut feeling that this was a bad situation. I got a gut feeling that this person I met was, not a good person. Like we have this second brain that's constantly responding to our environment in a way that our prefrontal cortex isn't. Our prefrontal cortex is trying to rationalize everything through language and vision in a way that our gut doesn't. And our gut is constantly responding. And so if you get a bad feeling about something, there's probably a reason for that. But our brain will try to push through that and ignore what the gut's saying because it can, right? We can rationalize situations. Look at people in like wartime situations. There are those who will run from the front line and be shot for deserting, and they're listening to their gut. Their brain can't cope with it. And there are those that, despite the fear, their brain overrides it and they still go into battle, right? And that's that difference between fight and flight. Some will gear up and go into it and keep going. Others will pull back. The people that pull back are the ones that have listened to the gut and they are too overwhelmed, so they've got to get out of it. The ones that who fight are overriding what their gut's telling them to do to a large extent, right? And so people will just carry on in the situation they're in rather than trying to find a way through it. They feel somewhat powerless in the situations they're in.
Plus, it's scary, like what is the statistics on your chance of dying the year you have major life events? Retirement, divorce is very significant. Like it's through the roof. So big life events are scary, and people know that as your community gets smaller, as you age, you're getting rid of a lifeline. There's this really interesting Taoist quote about that, and I know I'm going to butcher it, but there's this quote in Taoism about you need to become like the willow. You don't want to get stiff and break in the wind, right? That with aging, you need to actually learn to be more flexible because a lot of things are out of your control. But in our societies, there's not a lot to lean on, right? So if your spouse is the only other person you have, even if it doesn't work good, you just think, well, I'll just do this while I can. There's like a lot of societal and cultural and familial constructs that keep them there, but it's also very scary. And I think that's why mindset works. Like, so when we study like etiology of IBS, and it's the same thing with anything, like obesity is a good example. There are physical manifestations, and then there are psychological processes that can keep you stuck in that state or help you achieve remission. Right? So it's really both things. And I think just the way our society works is we kind of like to chalk it up to it's all physical. All you need to do is go to the doctor and fix it. So they might not see that relationship that like actually until a therapist tells them like maybe a change of job is good. Maybe it's time for a divorce. Like maybe you need to cut your borderline personality kid, adult kid that's still relying on you out of the equation. I don't think everyone makes that relationship, but it is always both. And it's always going, with the exception of acute infection and motor vehicle accidents, everything else in healthcare requires both. There's a physical cause and a psychological state that goes along with it. So, but yeah, not everyone knows that. Like I've met many people that come in and in questioning, like if we get a social history, which they're not used to even providing their personal details, they'll divulge this stuff and then they will start putting the connections. They're like, actually, my gut's fine. And then every time I see this person in my family, it's not, and I'm like, have you talked to mindset about this?
Mm.
Like, let's start working on that because there's only so much I can do with the food part, right?
Yeah, that's an interesting point. I hope everyone's enjoying this because I know we're not talking about food directly now, but that's the point. For so many clients that we work with, I mean, we know that food plays a role, but there's so many moving pieces to this puzzle, and what we're talking about now, I feel like no one talks about this. Where are you going to read about this information? So hopefully, are you guys finding it valuable? Let us know. Let us know in the comments. I noticed a really interesting comment from Deidre Waxman. Because I was saying like, well, people are not getting good advice or sent to the right places from the doctor. She said, my PCP sent me directly to this group after diagnosis.
Mhm. I was
Amazing.
going to say we need to it's
Yeah.
the PCPs that are on the ground doing all the work. So if
Hmm.
they're like,
Mm.
hey, there are these specialists that can help your clients achieve this outcome, and we work with you, like the GI docs, I taught GI fellows, like they definitely get taught procedural stuff, but they also think I know it all, so I'll just give this handout and monitor it myself, you know?
When I spoke with a lot of the gastroenterologists, like even at Digestive Disease Week, Tim, when we went in San Diego, and it felt like half the room were like, what has diet got to do with anything? Um,
Mm.
It's
and
that
so,
reductionist viewpoint. It's known in allopathic Western medicine as reductionist. And they're kind of fighting tooth and nail when there's all this research coming out that it's not what you do with your treatment, it's how your patient feels, if they have social support, like clinics that have peer educators, case managers, social workers, they have amazing patient outcomes and huge returns on investment. But like it takes decades in medicine to change it, right? So
mm,
when
Mm.
people used to have heart attacks, they would come to the ER and we would give them lidocaine injections in their heart because the whole theory was it's this contracted, tense muscle, and if we relax it, at least they won't die. And so they did that, and some physicians got suspicious that it was actually dangerous. And so they started doing study after study after study, and it took 30 years proving that that killed people for it to get taken out of the medical system. So there's these jokes in medical education. We used to joke like, I could teach you about something now that could be groundbreaking, 100% effective, and you won't read about it in your textbook for 30 years.
Mm. Crazy.
It is wild, but in the US, I don't know about Australia and like Malta where you guys are. We have like clinician rights and responsibilities and we have patient rights and responsibilities. And I don't think a lot of people in this country know about that. Like it's your right to get a second opinion. It's also your responsibility to get a second opinion. And
Mm.
when a diagnosis is wrong and you knew that they were wrong and you didn't go get a second opinion and then you try to sue for it, like you didn't fulfill your responsibility. So like this whole idea of like health literacy and patient empowerment and equity is huge now because we need the clients, like the patients to come in, the consumers of this to be like, actually, this is the change we want to see. But we're still stuck in that very reductionist thinking. And it's uncomfortable, right? So we study physicians. They're uncomfortable with ambiguity, and they will
Mm.
tend to try to get rid of clients that are confusing to their systems. Because guess what? They're also in fight or flight, and most of them I know have IBS and IBD and all the whole nine, all of it.
Half the bloody clinicians out there are, yeah, massively
Yeah.
struggling with their mental health. I see
Yeah.
Medscape articles on like the the specialty most likely to commit suicide, the specialty most likely to end up in divorce, and all these other sort of crazy statistics around medical professionals. It's very sad. But I do think the American medical system, and this is not a rant we want to go down in this call, but I do wonder how hard it is for some people to get their insurance to get them a second opinion on something. I know in Australia it would be a lot easier in a public system where you can just say, well, you can doctor shop here quite easily, right? You can doctor shop, you can hospital shop. It's in a system where you're not paying, you can go and get a second opinion. But I imagine it's harder in the US where you're tied into one insurance company, they have their preferred providers, and there's a relationship that doesn't want to be broken within those insurance systems.
Yeah.
But yeah.
I think the number one reason for bankruptcy in this country is medical debt. If that tells you anything. And most people are in the second half of their life when that happens. So yeah, it's a huge obstacle. But thank God we're here, because quite often we can advocate for them navigating the system, right? Because we're like, here, this is what we can do. This is what we need you to do, to advocate for yourself. And personally, I've seen clients get all these diagnoses they had no clue about because they're able to work with. So yeah, there's always ways. There's always ways, but it is a lot more work.
Yeah. But to try and bring us back on track a little bit, because we were talking about comorbidities and reasons why older adults might get digestive issues and IBS. I'll just throw out a few other possibilities, and Kirsten or Joe, you can talk to them. But we have childbirth and pelvic floor dysfunction that can lead to IBS, either shortly after birth or in the long term. We have sedentary behavior and not keeping the body strong, especially around the pelvic floor, which is different to one potential cause of why pelvic floor may weaken over time. We have reduced digestive capacity over time with all the organic aging of the stomach and the small intestine. And I've often seen people with low pancreatic elastase output, so low digestive enzyme output. And it may not be clinically significant to a doctor. It may not be pancreatic exocrine insufficiency, but it's low enough that it causes someone to have digestive issues, and it's worthwhile using an enzyme for that person, or at least trialing an enzyme. So those are just two other possibilities. Can you think of any others, Kirsten, that come up commonly for you? I mean, like you had
I don't know, like percentage wise, but I have a significant number of people that have allergies to certain things they're unaware of, like nickel or something like that. And there are many things that can mimic IBS that are actually a different pathway. Like lactose intolerance is a good one. So we used to think it was a benign but embarrassing condition. But when we biopsy the small intestines of lactose intolerance where someone's exposed themselves chronically over years, it looks like a celiac gut. So I think there's a lot of mimickers of IBS, and helping people like weed that out is one thing we specialize in, right? Because we can help them figure out, well, what is the reason for that? Like the pancreatic insufficiency is a good example. It is known to cause small intestinal bacterial overgrowth, and the vice versa is known too. So I think there are a lot. I'm trying to think, kidney failure, I specialize in nephrology, huge. Like the elimination organs, got your liver, your kidneys, and your gut. They all do this work together. And when one system's not working, when your kidneys aren't working, your gut tries to take up elimination. It gets overburdened and it weakens. Chronic laxative use, right? Or chronic opioid use, like pain control, narcotic bowel. I see a lot of narcotic bowel. I see that also. I don't think they term it the same thing when you use too much marijuana, but like I worked with a lot of HIV clients who used marijuana to cope with the symptoms and the stress of HIV, but with time that caused very IBS-like symptoms. And it's like 6 months of abstinence to treat that. So I think there are a lot of things like that. Infections are a big one too. Post-infectious IBS, especially with the more recent strains of COVID, we've seen a lot more of that.
So we know that like dysbiosis, which is the gut microbiome going out of balance, we could call it. that's thought to be a result of many things. We could say aging, but even long-term medication use, because you touched on some things there, so it made me think about it. And just thinking about if we can squeeze in this last topic maybe in a couple of minutes, but sort of the link between gut health and other health conditions, but more like and longevity and aging well. And I guess what is longevity? For me, it's like aging in a healthy way. So getting old, but healthy, not old and miserable. So is there any strong links with the gut microbiome and improving aspects of aging well?
Yeah, there's a lot of research on that. The hard part with that is it needs to start young. It needs to start decades before you even hit midlife. So that's the problem we run up against in many countries because it's hard to start like making changes later, although there's never a time that's too late. So, I specialize in lifestyle medicine. I don't know how many case studies I've seen of like 70-year-olds going to lifestyle medicine, changing their diet, their sleep, cutting alcohol out, making good, meaningful social connections, and then thriving for 20 more years. Like doing, Olympic competitions and like stuff like that. So, I think that, there's this relationship between frailty and dysbiosis, and they don't really know what that means, right? But we do see a connection that you tend to be more frail when your gut is not fortified and strong. And like to make it as simple as possible, like fiber and plant-based diet, like plants are what give the gut fortification, right? They literally provide you a microbiome that protects you from the outside world. It decreases your heavy metal intake, it decreases, toxic intake of whatever pathogenic or even pharmaceutical excess. So it's protective, and I think working on the gut can give you more quality of life. But I know that there are relationships between gut health and longevity, but there are some unknowns, right? Like you can't control your infectious exposure. Sometimes you can't control the medications you need to take. And so when those variables get taken out of your control, you have to think about the other ones. So sleep, exercise, relationships, social connection, especially those that include touch, diet. What am I missing?
Smoking,
Yeah,
alcohol,
smoking's huge, cutting
pollution.
smoking out.
Yeah.
Yeah, so like if you live within 1 mile of a highway, like your pollution exposure is massive, your risk of cancer and decreased longevity and all of that goes down. And that's hard to control sometimes, right? Like where you live, some countries are really burdened by it. But
Mhm.
lifestyle wise, like you can work on all those other things, even if you still need medication, to manage something, and you can still get quite a bit of movement. But I just have to mention too, like there are good, like 9 different theories on aging and longevity. No one's in consensus about what makes us live longest. All we know is that there's potential there. We don't know if it's related to telomeres or anything else. Like it's still something we're learning about. So.
Mm.
On the topic, Tim, you go.
I was just going to say, I think the focus on longevity and living longer is kind of pointless if your quality of life isn't good. I would rather live a short life that's high quality than a long life that's of poor quality, right? And I think that for me, especially in seeing older adults who've lived with digestive issues and poor health for a long time, I would much rather get them to a place where they have a much better quality of life, even if it's shorter, and to enjoy those years as best they can, than to be stressing over the minute details when they're, relatively well. Some people just focus on, I just need a supplement, I just need the fermented foods, or I just need to, I don't know. People focus on things that are like the top of the pyramid, and we don't need those bits. And they don't focus on the foundational things that will get them the quality of life that they deserve. And so they end up spinning their wheels with this poorer quality and longer term outlook of I just want to live longer, rather than let's do the basics to live well now, even if I don't live as long. So yeah.
On the topic of frailty and dysbiosis, Kirsten, that you touched on, I was just sort of scrambling my thoughts down so I wouldn't forget. But dysbiosis, I'm very fascinated by frailty, bone strength. I think of immune system. I think of a poor immune system when I think of frail. And so I know that there's if you think about the gut microbiome, um, helping with defense against pathogens, for example. So you've got the immune aspect of it. And so perhaps if the person has dysbiosis, then they're getting sick regularly, more susceptible to all sorts of infections and illness, and that contributes to frailty. That could be one of the things. And then I was looking at research, gut dysbiosis and other health issues, and the big one that came up was osteoarthritis. And I looked at a study that was mentioned, or the article was published on arthritis.org, which is the US Arthritis Foundation, I believe. And arthritis, by the way, is the number one cause of disability in the US, osteoarthritis. And it's all links at the moment. It's pretty early, but the concluding sort of sentence there was that they believe rather than wear and tear being the cause of, or the main contributor to osteoarthritis, which we're always told, right? Like, too much impact on the joints, that gut dysbiosis can lead to inflammatory proteins being leaked into the synovium which attacks your cartilage and leads to the wear and tear we see, and therefore the arthritis that results. And so I just thought, wow, if that's true, I feel like that changes so much, and that's so fascinating that that we haven't known that. And then I just thought that sort of reminded me about frailty and dysbiosis that you mentioned.
Yeah, there's a gut everything access now, but like that's what we see in psoriasis, right? One of the clinical trials I'm working on is psoriasis, and we have an arthritic and a non-arthritic trial going. And we see that. So like dysbiosis will lead to intestinal permeability, leaky gut, and that allows molecules to enter that initiate an inflammatory response, right? So when those molecules are floating around with no real job to do, they create mischief. So it's always about like our body likes to work, but it needs a job to focus on, right? And so like it'll get confused because it's all chemistry, right? It's all just seeking something it can have good affinity with. And so it makes messes. And it's the same thing with bone health in general. So I studied bone health for my master's degree, and you have about 5% bone loss. I think it was like per year in menopause. Like it's a significant decrease. And it's really important in menopause to eat a very polyphenic, antioxidant rich diet because it controls that. And when your bones get mineralized, all of the growth hormones and the interleukins, the inflammatory markers that are in that general facility, get put down in the matrix. So every time it remineralizes and it breaks down to rebuild new bone, it has this chronic, constant state of inflammation because they get freed, they do their thing. So I could see that happening in, when we take rheumatoid arthritis and we implement lifestyle medicine, we can put them into remission just with that. So it kind of makes sense that that would also be true. And your most susceptible part of your body is always what gets the biggest problem from low-grade inflammation, whether that's your endocrine system and you develop diabetes, or that's your joints and you get rheumatological or arthritic type of conditions. It's whatever is weakest. So that's why I say it's always comes back to your poker hand in life and whether or not you have the resilience to deal with it, because resilience is the key for you making the choices to take care of yourself, even when faced with really difficult things.
Yes, that's another topic for another time. Oh,
Yeah.
dear.